Good morning. Uh, Today we'll be discussing mitral valve disease. Again, it's the same concept, stenosis and regurgitation. And as usual, I ask you if you have any questions, burning questions. Later on, you can always contact me and I hope I can answer. So we'll start first with mitral stenosis. The etiology is rather limited here. It's rheumatic for all practical purposes. Again, all adults that we see have rheumatic mitral stenosis. Uh, Congenital is a complex disease. Usually it occurs in infants, of course, to be present at birth due to an abnormality in papillary muscles and the cords. So we don't see it in adulthood. It's just a disease of children. This is a nice schematic drawing of how mitral stenosis looks. It is the MS on the lower left. This is the heart. It's seen from above. If you make a section in the heart and look at it from above, the most anterior would be the pulmonary artery. Behind it is the aortic valve. And you can, this just for interest, you know that this is the aorta because the coronary ostia are seen emerging from the aorta. So this is the aortic valve. And in this schematic, of course, you understand that all three valves appear chromatic or thickened with commissural fusion. So the mitral is on the posterior aspect of the heart, and it's on the left side, of course, if we're looking from above. Other views show how mitral stenosis looks from the left ventricle with the papillary muscles and the chordae attached to the leaflets, but the leaflets are thickened and the orifice is narrow. So, what's the pathophysiology? With mitral stenosis, blood has to pass through the narrowed valve in diastole, of course, because this is when the mitral valve is open, from the left atrium to the left ventricle. So if there is a narrowing in the mitral valve, the left atrial pressure will have to rise to propel the blood across this stenosis. So if the left atrial pressure rises, the pulmonary vein pressure rises, and the pulmonary venous pressure, of course, receives blood from the pulmonary artery through the capillaries, pulmonary capillaries. So if we were to measure pressures, this is the pressure in the left atrium, the lower curve. We have the EKG, which tells us that we are looking in diastole, which is the period before the QRS. And so the left ventricular diastolic pressure, as is always the case, it's normal. It's 10 millimeters and less. Here in this tracing of this patient, it's even less than 10 millimeters. So you have a low left ventricular pressure, and the left atrial pressure is always a bit higher for blood to pass from the left atrium to the left ventricle. What happens in mitral stenosis? As we see on the curve on the right side, on the tracings on the right side, the left atrial pressure has increased significantly. It's now between 30 and 40 millimeters of mercury, okay? While the left ventricular diastolic pressure remains low. less than 10, okay, early in diastole and up to 10 in late diastole. So now we talk of a pressure difference between the left atrium and the left ventricle in diastole, a pressure gradient, and this, of course, is governed by the severity of the stenosis and a few other factors which I will talk about in a while. I have the habit at this stage to remind you all of the pressures in the heart. Sure, you studied them, but let's go over them again. Just for you, Hickey, to be when we talk about pressures, for us to understand the what numbers we are talking about. So we start with the right atrium. Look at the scale. So the right atrial pressure is about 5 millimeters mercury. You have the A and the V waves. We'll elaborate on them in a while. The first, we go then to the right ventricle. The first concept is that the atrial pressure and the ventricular diastolic pressures are usually in the same range. So the right ventricular diastolic pressure is similar to the right atrial pressure. However, in systole, the right ventricle has to eject blood into the pulmonary artery, so the systolic pressure in the right ventricle goes up. Here it's around 25 millimeters mercury. The normal right ventricular systolic pressure is about 25 millimeters. It follows that the pulmonary artery pressure is similar in systole. It is around 25 millimeters mercury. However, in diastole, when the pulmonary valve closes, the right ventricular diastolic pressure drops. However, the pulmonary valve prevents the pulmonary artery pressure from dropping, similar to what happens in the left heart with the aorta. So you have a higher pulmonary artery diastolic pressure around 10 to 12 millimeters. What's the capillary wedge pressure? This is a reflection of the pulmonary venous pressure. It's when you wedge a catheter, you push it to the end through the pulmonary artery, pulmonary arterioles, until you reach the capillaries, where the catheter cannot advance any further. It will start measuring the pulmonary venous pressure. So the pulmonary capillary wedge pressure is similar to the pulmonary venous pressure and the left atrial pressure. So again, you have an A and the V wave like the right atrium, but the value now is higher. It's around 10 to 12 millimeters, similar to left atrial pressure. So we go down to the left atrial pressure in the left lower corner. And this left atrial pressure, as we just explained on the right side, is similar to the left ventricular diastolic pressure. However, in systole, the left ventricle generates a higher pressure, around 130, 140, 150 millimeters, depends. And the aorta, as we know, the systolic is like the left ventricular, but the diastolic is higher because the aortic valve is closed in diastole. And you remember from the last lecture that left ventricular systolic pressure may be even higher when you have aortic stenosis. So, going back to the mitral valve, what factors affect the gradient across the mitral valve for a fixed stenosis? So if you have to push more blood across the stenosis, for example, with the higher cardiac output, the gradient will be higher. Another factor that we don't elaborate on a lot in aortic stenosis, in mitral stenosis, this happens in diastole. The flow of blood happens in diastole. Now, the diastolic interval varies depending on the heart rate. So if you have tachycardia, diastole will become shorter. This is the only way to increase your heart rate is to shorten your diastolic interval. So with a shorter diastolic period, you still have to push the same amount of blood or maybe higher amount of blood within a shorter period of time. Therefore, the left atrial pressure will go up. So the gradient rises with a higher cardiac output, and the gradient rises with increased heart rate. Why? Because the diastolic interval becomes shorter. Then at the end of diastole, you have the atrial contraction. So if you lose the atrial contraction, which will help to empty the left atrium, for example, in atrial fibrillation, condition that will lead to quivering of the left atrium no longer contracts, you lose the atrial kick, and therefore the left atrial emptying will be impaired. So this is just a visual example of how shortened diastole increases with increased with exercise will raise the left atrial pressure. We have curves on the left at rest, resting, showing the left atrial pressure with the A and V waves and the diastolic left ventricular pressure, and you have a mild gradient across the atria, across the mitral valve in diastole. However, with tachycardia, you see that diastole becomes shorter, and as diastole becomes shorter, the left atrial pressure goes up. So a patient with mitral stenosis, when they exercise, the left atrial pressure goes up and they become short of breath. So what are conditions that will increase cardiac output and affect the gradient across the mitral valve? As we said, exercise because of increased cardiac output and because of a shorter diastole from tachycardia. How about people with fever? Anybody who has fever will have higher heart rate, and because of vasodilatation with fever, their cardiac output goes up. So this will make the gradient higher. How about anemia? You have to pump more blood to the tissues because the oxygen in the blood is less. Another important or interesting phenomenon is pregnancy. With pregnancy, the cardiac output goes up significantly. And patients with mitral stenosis do not tolerate pregnancy at all, usually after the second trimester. Because of this rise in cardiac output, they become very sick if they have a significant mitral stenosis. So keep these factors in mind. What about numbers? The normal mitral orifice is around 4 square centimeters. Moderate MS is between 1.6 and 2 centimeters. Severe is 1 to 1.5 square centimeters. In the past, we used to consider 1 to 1.5 as moderate MS, but the recent guidelines, now 1 to 1.5 is severe, but they introduced a new term, which is very severe mitral stenosis when the area is less than 1. So these are the numbers we have to remember. Now, coming to further pathophysiology, this is a very nice diagram, at least I think so, which shows us the left ventricle, the left atrium, pulmonary veins, the lungs, pulmonary capillaries, the alveoli. So blood goes from the right atrium to the right ventricle, pulmonary arteries, and of course, where it gets oxygenated, and then moves to the left atrium and left ventricle. What happens in mitral stenosis? First, you look at the left, you see that the mitral valve is now more thickened and narrow. So, first thing that happens is that the left atrial pressure will rise. And With time, a high left atrial pressure will lead to dilatation and enlargement of the left atrium. Well, the left atrium is a thin-walled structure, so with the high left atrial pressure, it sort of stretches and dilates. The pulmonary veins also dilate because they are engorged with the high left atrial pressure. And when the high left atrial pressure is very high, you can have a condition called pulmonary edema, where there will be transudation of fluid into the alveolar spaces. And the patient will be very sick. They will cough what you call frothy sputum. That's fluid mixed with air, so it becomes frothy, الرغوة. And sometimes even there will be exudation of blood into the alveoli, and they can cough bloody secretions, which is called hemoptysis. Now, let's look at the right side. Since the left atrial pressure is high, you have to raise the pulmonary artery pressure in order to be able to push blood so that blood will continue to go from the right side of the heart to the left side. So now you have a condition of what you call pulmonary hypertension, and there will be some changes in the pulmonary arteries, fibrosis, etc. And who generates the high pressure in the pulmonary artery? The right ventricle. So the right ventricle, now that it's working harder to generate a higher pressure, will have to hypertrophy. After several years of hypertrophy in the right ventricle, similar to what we learned in aortic stenosis and aortic regurgitation, any hypertrophied ventricle is going to fail. So when the right ventricle fails, it dilates the what you call the tricuspid valve annulus will dilate because of the dilatation of the right ventricle, and you can develop tricuspid regurgitation. With tricuspid regurgitation, you're going to have what you call right heart failure. The patient will have a congested, engorged liver. You will have leg edema, maybe late, and sometimes fluid in the abdomen called ascites. So we started with mitral stenosis. We ended up with severe right heart failure. Mind you, what about the left ventricle? The left ventricle is distal to the mitral valve, so it's usually not affected by mitral stenosis. So this is just to document what we just discussed. So you can have pulmonary congestion, dyspnea, paroxysmal nocturnal dyspnea, which when they wake up at night with dyspnea, pulmonary edema, of course later on pulmonary hypertension, right ventricular pressure overload and hypertrophy, later right ventricular failure and dilatation, and tricuspid regurgitation. I hope this is clear. Some other clinical complications. As we said, we can have hemoptysis from pulmonary edema when there is a very high pressure in the pulmonary veins and some RBCs enter the alveoli and the patient coughs blood. Another complication that happens is the bronchial veins are also dilated because they empty into the left atrium. So when you have high left atrial pressure, the bronchial veins may dilate, and a rupture bronchial vein can give you frank hemoptysis. Okay. Another complication when you have a dilated, stretched left atrium is that you develop atrial fibrillation. Now, the problems with atrial fibrillation, as we said, you lose the atrial kick, the atrial booster function is lost. However, more important is with atrial fibrillation, you develop stasis of blood in the left atrium. And with stasis and the lack of contraction, plus with the presence of the mitral stenosis and the blood is not emptying well from the left atrium, you develop thrombus in the left atrium. And we'll see in a minute where this happens. So when you have a thrombus in the left atrium, there is a chance of that this thrombus can dislodge and it can lead to an embolism. And we'll talk about it in a while. Finally, you can have complications of any diseased valve. You can have infective endocarditis where bacteria will work on the valve and destroy it. So let's look at atrial fibrillation. The site which is most favored for thrombus to occur is the left atrial appendage, which is a protrusion from the left atrium. And because it is sort of a dead end, stasis of blood occurs in this appendage and thrombus may be present there. This is the most important site for thrombus formation in the left atrium. This is just by what you call transesophageal echo. We have a probe placed in the esophagus looking at the heart through the left atrium. This is the first structure we see at the apex of this triangle is the left atrium. And we see that there's a protrusion of the left atrial wall, which is the left atrial appendage, and this is filled with thrombus, and the tip of the thrombus seems to be moving. So this is just waiting at any moment to dislodge, go through the mitral valve into the left ventricle, ejected into the aorta, and it can end up in the brain where it can cause a stroke, can go down to the lower extremities, occlude an femoral artery, etc. So this is systemic embolization is a very important complication, and all patients with mitral stenosis and atrial fibrillation should be on anticoagulation so that this thrombus does not occur. Coming to the murmur of mitral stenosis, I hope you will bear with me on this. So, as we know, flow of mitral stenosis occurs in diastole, so it occurs after S2. Now, after S2, there's a period which is called the isovolumic relaxation period, after which the mitral valve opens. So, ideally, there should be no flow or no murmur heard between the closure of the semilunar valves, the aortic and the pulmonic valves, and the opening of the mitral valve. As soon as the mitral valve opens, you get this red line, and it is called an opening snap. Why? Because the mitral leaflets, because they are a bit thickened, when they open, they make a sound. It's like if you're holding a paper in your hand and you move it abruptly, quickly, it will make a sound. This is similar. It's called an opening snap. After the opening snap, you will get a murmur of diastole. It's high in early diastole. It becomes less important in mid diastole because the left atrial pressure will have dropped a bit. And then with the atrial contraction, the murmur accentuates again. Then you have S1, which is the end of diastole. Now, what happens with more severe mitral stenosis? If you notice, the red line has come closer to S2. Why is that? Because with severe mitral stenosis, you have a higher left atrial pressure. So the mitral valve is going to open earlier. So the isovolumic relaxation period will be shorter. Why? Because of the high left atrial pressure trying to open the mitral valve. And so you get a shorter opening S2 OS interval. This is how it's called. S2 opening snap interval. Finally, when atrial fibrillation sets in, as we said before, there will no longer be atrial contraction. So there will this uh, accentuation of the murmur at the end of the diastole will no longer be there. Loss of presystolic accentuation of the murmur atrial fibrillation. It's written here. Okay. So what's the difference in the diastolic murmurs between aortic regurgitation and mitral stenosis? Aortic regurgitation starts immediately after S2, while in mitral stenosis, you have this isovolumic relaxation period, uh, after which the mitral valve opens and you start having the flow. And the opening of the mitral valve is heralded by what you call the opening snap. Pulmonary regurgitation is similar to aortic regurgitation. Patent ductus is not to be discussed today. How do we manage mitral stenosis? The simplest way, this was the oldest technique, is to try to slit open the commissures, what you call a mitral commissurotomy. Now, in certain situations, instead of doing a mitral valve replacement which needs open heart, you can do a balloon valvuloplasty. As you know, that many problems in the heart these days are treated with balloon dilatation, the coronaries, etc. Why not also the mitral stenosis? How is it done? This is a catheter. If you look at first figure A, the catheter has passed from the femoral vein through the inferior vena cava into the right atrium. Then you have to cross the interatrial septum. Usually, you may need to perform a small hole in the interatrial septum to cross. Once the catheter is in the left atrium, it will be deflected down, as in figure B, to cross the mitral valve. In C, there's a balloon inside this catheter which is inflated. And as you see in D, when this balloon is inflated, it will sort of tear open the mitral valve. Of course, it's not without its complications, but if it works, it can open the mitral valve and it will become less stenotic, so the patient will be less symptomatic. If we decide to go to surgery, we'd have to insert a prosthetic valve. These are just examples of modern valves. On the left, we have what you call the biologic valve, which is made from porcine tissue, pig, or bovine tissue, cow, or even sometimes human pericardial tissue. So that you make a bioprosthetic valve. The problem with these valves is that they don't last long, 8, 10, 12 years. But the advantage is that they don't need anticoagulation. Whereas if you put a mechanical valve on the right side, which is made of some rare metals, etc., inert metals, they can last years, 20, 30 years, but the patient should always be on anticoagulation. And if you listen with your stethoscope, when you have a mechanical valve, you will hear what you call a click. It's like any metal ticking. You will hear the sound, and it's called a metallic click. Let's move on to mitral regurgitation, which is the last valve problem we're going to discuss. Now, looking at the anatomy of the mitral valve, uh, many things can go wrong and cause mitral regurgitation. Starting from the muscles of the heart, you have the papillary muscles, and attached to the papillary muscles are the chordae tendineae, which in turn are attached to the mitral leaflets. Then you have the leaflets themselves, and finally you have the mitral annulus. So anything that goes wrong with any of these structures will lead to a form of mitral regurgitation, as we'll learn as we go along. So we have two broad categories of classification of mitral regurgitation. Primary is when there's a disease of the leaflets themselves. For example, rheumatic fever. We're going to talk about mitral valve prolapse. We're going to talk about chordal rupture, which occurs with mitral valve prolapse, and endocarditis, as we said, when bacteria infect the valve and eat it up. But we have another quite important cause, which is dilatation of the mitral annulus or tension on the leaflets due to papillary muscle displacement or enlargement, which we call secondary mitral regurgitation. So secondary mitral regurgitation, there's nothing wrong with the leaflets themselves, the valve leaflets. It is a disease of the supporting structure, as you would want to say, dilatation of the annulus or of the problems with the papillary muscles, the position of the papillary muscles. We'll elaborate on. The first common and interesting pathology is what you call mitral valve prolapse. If you look on the left side, how the mitral leaflets close in systole and open in diastole. If you look on the right side, you find that one of the leaflets sort of forms a hump in systole. This is what you call mitral valve prolapse. Now, simply, if you have this hump, but the leaflets are still touching, you will have what you call the syndrome of mitral valve prolapse with what they call a systolic click, but they don't have any regurgitation. However, if this prolapse is more severe, then you're going to have mitral regurgitation. This is by echo. On the left, I hope you'll be able to understand without my explaining. We have the mitral valve sort of opening and closing. It's very clear. Huh? On the right side of this picture, there's the left atrium, and on the left side is the left ventricle. So when the mitral valve opens, blood flows from the left atrium into the left ventricle, and you can see the leaflets how they look. What about on the right side? If you notice that what you call the posterior mitral leaflet is longer than the one on the left, and it forms a sort of a hook in systole. It's curved inside into the left atrium in systole. So this is what you call mitral valve prolapse, and it's associated with various degrees of mitral regurgitation. This is how mitral regurgitation will look by what you call color flow Doppler. So this is a schematic of what we just described. On the left side, this is the normal heart, showing a mitral valve that's closed in systole and blood being injected into the aorta. The thick arrow, the blood is injected into the aorta in systole. On the right side, we see mitral valve prolapse, significant prolapse of both leaflets. You see how they form a hump into the left atrium. And with this hump, the leaflets don't close as well, and hence you will have leakage of blood into the left atrium, what we call mitral regurgitation. So this is prolapse and regurgitation. Now, mitral valve prolapse is, we are elaborating on it because it's a common congenital abnormality. It's due to weakness in the connective tissue that leads to a floppy and redundant valve, and even the chorditendiny will be also lax and will contribute to this problem. And as we said, you can have simply a click from mild mitral valve prolapse to mild mitral regurgitation to moderate and even severe mitral regurgitation, and sometimes you will have the regurgitation will not be severe, but overnight one of the cords, the chorditendiny, will rupture, and suddenly the valve becomes severely regurgitant. So let's talk about the pathophysiology of mitral regurgitation in general. So normally the left ventricle will eject blood into the aorta. Now, when the venous return enters the left ventricle, part of the blood will go into the aorta and part will go back into the left atrium. Also in this diagram, you see it. Part of blood is going into the aorta and part in the left atrium. Now in diastole, the blood in the left atrium that comes from the venous return, plus the one that was regurgitated into the left atrium, will have to go back into the left ventricle. So this will lead to what you call a volume overload state. That the left ventricle is now receiving excessive blood in diastole, and it has to accommodate this excessive blood, and this will lead to what you now are seeing, eccentric left ventricular hypertrophy in the lower right corner. Okay, the left ventricle has to dilate, and when it dilates, it hypertrophies. But this type of hypertrophy is eccentric, as opposed to concentric hypertrophy, which we saw in aortic stenosis. Eccentric also would occur in aortic regurgitation, as we learned in the previous lecture. Going back to our famous pressure volume curve, you can have chronic or acute regurgitation. And let's talk about chronic regurgitation. The ventricle dilates, so its volume will increase, but because this happens gradually, this dilatation will allow accommodation of this excessive volume, and the diastolic pressure in the ventricle will remain almost normal. So, example, you're filling the ventricle 140 cc's instead of 80 cc's, but your diastolic pressure is not affected much. However, if the regurgitation happens quickly, as I said, for example, from a ruptured cord, etc., you will be on the curve in the middle, and so with filling the ventricle with only 20 or 30 cc's extra will lead to a significant rise in left ventricular diastolic pressure. So, reiterating what we said, eccentric hypertrophy due to replication of sarcomeres in series, and in chronic mitral regurgitation, you have a right shift in the pressure volume curve, and the LVEDP remains within normal when you have a right shift in the pressure volume curve. Now, another variable that comes to play is the left atrial size. Okay, so as the left ventricle dilates from the volume overload, the left atrium will also dilate from the volume load, venous return plus whatever is regurgitating into the left atrium. So the figure on the right, where the orange arrow is when the left atrium has time to enlarge, and it's called a compliant left atrium. Why is it important? Because in systole, when the blood enters from the left ventricle, and you remember that the left ventricular systolic pressure is high. It's around 110, 120 millimeters mercury. So blood entering the left atrium under this high pressure and, and the volume that's entering, if the left atrium is compliant and large, the pressure in the left atrium is not going to rise very much. So when you have a compliant left atrium, the left atrial pressure will not rise a lot. And as we said, the left ventricular diastolic pressure is not high. So the patient may not have a lot of symptoms. Now, the counterpart of this is, suppose a patient has a small or normal sized left atrium and he develops acute mitral regurgitation, as we said, like a chordal rupture of a chorda tendini. Sometimes even the head of a papillary muscle in very rare situations may rupture. So you suddenly develop severe acute aortic mitral regurgitation. The left atrium is small and it cannot accommodate this extra volume under high pressure because it's non-compliant, it's still small. These are the causes: ruptured papillary muscle or chorda tendini, or if you have a bad infection of the valve, endocarditis. So what happens to the pressure in the left atrium? Let's go back to the details of normal left atrial pressure. Like the right atrial, like we have learned in physiology, we have the atrial tracing has two waves, what you call the A wave and the V wave. The A is due to contraction of the atrium after the P wave of the EKG. After the QRS, you enter systole, where supposedly the mitral valve is closed, and the V wave that we see here is simply due to passive filling of the atrium from the pulmonary venous return. I think this rings a bell with you. Now, let's imagine what would happen to this atrial pressure in systole if there was blood entering from the left ventricle. And as I remind you, the left ventricular systolic pressure is high, 100 millimeters, 120 millimeters. So if we were injecting blood into a small left atrium at the pressure of 100 or 120 millimeters, what's going to happen to this pressure? We see here the left atrial pressure now has risen severely. It's around 70 millimeters. If you look at the tracing, the pressure on the left side. And what do we call this? We call this a tall or a giant V wave. Giant V wave is a popular term. The cause of this giant V wave is what? Is the mitral regurgitation jet entering the left atrium, and when the left atrium is small. So please, we have to, I hope, understand this concept. So a giant V wave is due to severe mitral regurgitation that happened rather suddenly when the left atrium is small and cannot accommodate the volume. What about the pulmonary venous pressure? Of course, it's going to go up. How about the possibility of pulmonary edema? Very likely. So the patient, because of the high left atrial pressure, pulmonary venous pressure, the patient will be very sick. What you call pulmonary edema, severe dyspnea, etc., etc. So this is a sort of a comparison between acute mitral regurgitation and chronic mitral regurgitation. First of all, look at the left ventricle, the curves in the middle to remind you. So you have an acute rise in LV-EDP since the LV is not dilated. Left atrium, also acute rise in left atrial pressure since the left atrium is not enlarged and it's not compliant, and the patient is very sick. However, in chronic mitral regurgitation, as we said, the pressure volume curve in the left ventricle has moved to the right, so there is no major rise in LVEDP, left ventricular end diastolic pressure, no rise in left atrial pressure because the left atrium is compliant and the patient does not have a lot of symptoms. So people can have severe mitral regurgitation with no symptoms. بيقول لك حكيم أنا ما حاسس بشيء. But we'll see later on where the catch is. So what about the murmur of mitral regurgitation? Depends. If you have a rheumatic mitral valve, from the moment the valve closes, it's going to leak. So you're going to have a murmur starting immediately after S1, after closure of the mitral valve. And this will be what you call a holosystolic murmur of mitral regurgitation, holosystolic or pansystolic murmur. However, there are other conditions we want to talk about. Look at the lower left corner. We see the mitral regurgitation, as we said, with the holosystolic murmur. What about the upper right corner when you have mitral valve prolapse? Remember, I told you about this hump and the click. So mitral regurgitation may not start immediately after S1. You have to wait for a while for the valve to sort of arch into the left atrium, give you the click, and then you will start having the mitral regurgitation murmur. So the murmur now is mid to late systolic murmur preceded by a click. This is the classical description of mitral valve prolapse. One day you may have the fortune to hear it on a patient. It would be very interesting. So in mitral valve prolapse, the mitral regurgitation does not occur from the beginning of systole, it occurs in mid to late systole. So what's the cause of chronic mitral regurgitation? As we said, the left ventricle will hypertrophy. What kind of hypertrophy? The eccentric hypertrophy, the one, the lower diagram. And if you leave this hypertrophied ventricle working for years and years, it will end up failing. You will have decompensation. So any hypertrophy ends up in decompensation if left alone. What do? We have to correct the mitral regurgitation. When do we correct it? There are many studies. So they look at the size of the left ventricle and function before and after mitral valve replacement in many patients. And in general, many patients showed a decrease in left ventricular chamber size, which is good, after you correct the mitral valve regurgitation. So you can regress the hypertrophy, you can regress the dilatation if you act in a timely fashion. However, about 25% of patients, their ventricles did not go back to normal after you replace their valves or correct the mitral regurgitation. And what was the best predictor of a good outcome? If you send them to surgery while their ejection fractions are more than 60%. Look at the curve on the right. Look at survival. The highest survival is for those whose ejection fractions is more than 60%, the thick black line, okay? The dotted lines in the middle and the lower line are people with lower ejection fractions. So the lower ejection fraction, when you send the patient to surgery, the poorer outcomes they will have post-op. Okay, so we do not want to wait until the ejection fraction drops before we send them to surgery. We may have to send them if we see our patients for the first time when they have low ejection fraction, but We prefer, if we are following up our patients, to send them before this happens. So, what parameters can identify patients with mitral regurgitation who will not have a good outcome? A low, normal, or depressed pre-op left ventricular ejection fraction. Number two, by echo, we can measure the diameter of the left ventricle. If you remember, in aortic regurgitation, we talked about a left ventricular end systolic dimension of 50 millimeters mercury. In mitral regurgitation, the number is 40 millimeters. So when the left ventricular end systolic dimension approaches 40 millimeters, this is the time where you should send your patient for mitral valve correction of the mitral regurgitation. I'll explain why I'm using these terms. So just for you to know, the end diastolic diameter of the left ventricle, the normal is between 3.5 and 5.5. End systolic, the normal is up to 4. In aortic regurgitation, you can wait until it becomes 5. But in mitral regurgitation, when it reaches 4, you should act. And this is just a repetition of what I just said. If the ESD exceeds 40 millimeters, then you should consider surgery. Or if the patient has symptoms, he has heart failure symptoms, at any ejection fraction, you should operate, preferably more than 30%, because when it's less than 30%, they don't do well at all. I will not belabor the final point, which is why the ejection fraction may appear falsely increased in mitral regurgitation, because this is not, it's going to be difficult to do this without face-to-face interaction. So what do? We can replace the valve, as I showed you before, biologic or mechanical valves, or we can do sometimes in prolapse repair. And this is very popular these days. Why? Because you are sparing the patient a prosthetic valve. You don't put a prosthetic valve. If you look at the picture above, you will see sort of a bulge in the middle of the mitral valve. This looking from the left atrium. This is what you call mitral valve prolapse, how it looks. So they can excise this prolapse portion, and you see below that there are stitches now where the prolapse portion was, and they put usually a ring. This is a technical issue, but usually you put a ring. That's all. You don't have a mechanical valve that needs anticoagulation. You don't have a bioprosthesis that will fail after 10 years. So repair is a very promising way to deal with prolapse and mitral regurgitation. Finally, sorry if I'm taking a bit more time, we have to talk about secondary mitral regurgitation, which is not due to the valve itself, leaflets themselves, it is due to the ventricle. So this is an example of a normal ventricle on the left with the chordae and the mitral leaflets. If the ventricle, for example, develops a myocardial infarction and the area where the papillary muscle arises is displaced a bit outwards, the chordae will not allow for adequate closure of the leaflets, what you call tethering. They are pulled, the chordae are pulled by the papillary muscle, which is displaced. And so the leaflets don't close, and you get mitral regurgitation. This is secondary mitral regurgitation. So this is another example of a myocardial infarction where the papillary muscle has been displaced outwards, and now there is no longer adequate closure of the valve or coaptation leaflets, and that's why you have mitral regurgitation. Also, in dilated cardiomyopathy, whenever the heart enlarges for any reason, you can have a pull on the leaflets and they don't close well, and you will have what you call a secondary mitral regurgitation or functional mitral regurgitation. The treatment is optimization of heart failure. Try to improve the contractions of the heart, maybe diurese the patient to make the heart smaller. Very rarely do you go for surgery in secondary mitral regurgitation. However, there's now a new technique called mitral clip, where again percutaneously, like we did in mitral balloon valvotomy, through the you introduce catheters through the veins to the heart, and you can try to attach a clip. If you see on the right side, there's a clip that's holding the two leaflets together. If you look on the left, there's a cross section like the owl eyes, as they liken it. So now, when the two leaflets are brought together, you will decrease the degree of mitral regurgitation, and this may help the patient. So mitral clip, this is another new fancy technology that we have that can be used to treat functional or secondary mitral regurgitation. Thank you. Sorry, it took maybe a few extra minutes. And this is my email if you don't want to look it up. And you can always ask me questions if you wish. Thank you.